day set aside to talk about stigmatization, those who are going through HIV/AIDS, how you can be supportive towards them, and caregivers, and all of that. Today, we'll be discussing with a team from the AIDS Healthcare Foundation, and we'll also be talking to Dr. Suprina Oligbi. Did I get your name right? Okay. I will have Dr. Fatima Dagash, that's it. Dr. Fatima Dagash, who is the coordinator AIDS, STI, and Hepatitis Control Program of the FCT. We also have Dr. Egonu Ifeanyi. Thank you so much for being. He is a regular here. He's the State Clinical Coordinator, AIDS Healthcare Foundation.
Thank you very much.
I beg your pardon?
Thank you very much.
Right. We'll get to that conversation of what we should be doing. How can communities lead, which is the theme for this year's celebration. Thank you so much for being part of the program. I think we'll just first of all go to HIV and AIDS. A lot of people think it's over with, it's done with. There was such a time the campaign was very rife, and now not so much. What's going on with that advocacy? Have we overcome it? Is the advocacy or awareness for it enough? What's going on?
Well, technically, I would say that advocacy for whatever disease, HIV included, can never be over. So we continue to advocate, we continue to make people aware. Probably the reason why you feel that you don't hear so much about HIV is that we're beginning to reach what we call epidemic control. And with that, it means that the number of cases for HIV is declining, and that is going to show you that all the control measures that we have put in place seem to be working, and we're sustaining those measures as well. So what we're doing now is that as we reach epidemic control, we are also still making people aware that the disease is still there, but we're trying to stop transmission of the disease. So now we're actively working on stopping transmission of disease, and when you hear that you're not hearing so much about it, it's because we've moved from prevalence, at least for the FCT, from many years ago of about 7.8% to, as of the last NICE study in 2018, to 1.3%. So that's a very big difference in how many new cases we're getting. So that's why probably people think that it's not there anymore, but it is. It's just that we're reaching epidemic control, which is a good thing as well. Yeah.
Okay, for people who might be
yeah, just like she said, and one key thing about we having HIV/AIDS program, what is the program as the team, it's not over yet, because the truth is it's really not over. A lot of persons, there are still new cases that is still coming up, and one key thing you need to understand, we also have to work in tandem with the UN AIDS 95 to ensure that we end HIV and AIDS by 2030. In as much as we know that there are still going to be new infections, that's why we know that it's not yet over yet. No matter the number, if one person is infected with HIV, is a big, and in fact is a great concern for us as AIDS Healthcare Foundation. And that is one key thing. Again, we have to really work closely with our partners, the FASCAP, the WHO, NACA, every other agencies in fight for HIV and AIDS, because it's really not over. And one of the key things for the global HIV, what it's it's let community lead. And if the community is leading, it means that we need to really integrate our services in the community to ensure that everybody is tested, people know their status. Not only do they know their status, those who are positive, who test positive for HIV should be in care, and those who are already in care should also achieve viral suppression, at least test not detected, to enable prevent the transmission of the virus, so that the new cases wouldn't be coming up. And another key thing that we know is that so many people are living with HIV and they don't even know their status, and that is why AHF has collaborated with FASCAP to make sure that we create awareness. We spin the ball to make sure awareness campaign is key thing to really ensure that people are aware that this HIV itself still exists, and issues surrounding stigma around HIV. That makes a lot of persons not even willing to even get tested because they're even afraid of even getting tested. We want to commonize HIV. We want HIV to be like malaria. You want people to like, we want to go and get your genotype, your test, your typhoid test. This is how we want HIV to be, so that the issues surrounding stigma around HIV will become a total, and that way we can drive the end of HIV by 2030.
Okay, that brings us to what you do at FASCAP, that is the FCTA, STI, and hepatitis control program, and they are talking about letting the communities lead. What really characterizes your activities?
So generally, the FCT AIDS and STI control program is domiciled in the Department of Public Health, which is under the Health Services and Environment Secretariat of the FCT. And basically, we drive the response like it says, particularly the health sector response now, in collaboration with FACA, which is the FCT AIDS control agency, which does the coordination and the preventative part of HIV. But we drive alongside all our relevant stakeholders like the AIDS Healthcare Foundation and other stakeholders that work with us in the state to make sure that the health sector response is coordinated. So yes, we do things like the awareness, to ensuring that there's the WHO guidelines of testing and treating, making sure that the medication is available through PEPFAR. We're making sure that people we do a barrage of things. So from the time you walk into the hospital and get an HIV test till the time that you are linked to treatment, your viral load is being checked, whatever, we follow the person. If it is a pregnant woman, we follow her throughout the pregnancy till we make sure that she delivers, hopefully, if she goes through the program properly, an HIV-free infant. So all of these are the things that we do generally at the state level. So alongside our partners at the local government level, at the facilities, the PHCs and so on. And we have so many facilities in the FCT, almost about 400 of them, that offer at least HIV testing services. We have something we call the hub and spoke model. So obviously some facilities are bigger than the others. So you may get tested in all of them, but if you are going to be linked to treatment, should you be positive, you may be moved to a bigger one so that you can get a better and more holistic care. But generally, that's what we do at FASCAP.
Okay, so when you say let communities lead, very often we look at governments to show us the way. How can communities lead in this fight to completely eradicate, if possible, HIV?
Maybe if we give you a little bit of a background as to why the particular theme for Let Communities Lead was chosen this year.
Right.
So I want to believe that it's just to mark like he had previously said, is to mark the pivotal role that communities play in the HIV response. Now, when we say communities, we're not only talking about government or implementing partners like them. We're talking about the CSOs. We're talking about the mentor mothers who are in the facilities. We're talking about the chiefs, the stakeholders, the grassroots people. So the chiefs, it's the emir, it's the religious leader that helps us, it's the matron at that little hospital, it's the market women, it's the PLHIV themselves, that's the people living with HIV in their own communities. So we're talking about all of these communities because the HIV response is not being done by government alone. Government cannot do it alone. We have to work with these pockets of communities who know themselves, where most people are more responsive to people they know, people they trust. So you must use these communities to get to the vulnerable people, and people living with HIV are vulnerable because, like he said, the stigma is still around. The people are afraid to find out their status because they still think that, okay, if I have HIV, then what happens? Or I may just die, or, and so on. So these communities play a very vital role in making sure and ensuring that the HIV response gets to where it needs to get to, and the right things are being done. So that's the reason for choosing Let Communities Lead this year, yes.
Okay, she just talked about implementation partners and the different CSOs who can be part of this. What has been the reception in ensuring that these people, traditional heads, religious heads, come together to push this narrative?
Okay, and that's just like she rightly said earlier, in terms of the community leading the program, in terms of HIV status for people within the community to get to know about their status and also to embrace treatment, because the main thing here is you embracing the treatment once you're confirmed positive for HIV. And once you're confirmed positive and you've embraced treatment, and then the tendencies for you to have viral suppression becomes very, very vital. And once you're virally suppressed, the chances of transmission becomes very low. So the key people in the community, the stakeholders, we talk about the church leaders, we talk about the imams, we talk about religious leaders. All these are people that we integrate our services with by really giving them the top-notch knowledge, intimating them how HIV transmission happens and ways to prevent this HIV transmission. And once they have this information and knowledge, they can now guide the community to which they listen to. You know, often well known in Nigeria, we listen to our community heads, we listen to our religious heads and all that. So that drive will help necessitate the necessary information that people should know about HIV. HIV does not kill. The issues surrounding it in respect to as a death sentence is foregone alternative. Right now, once you are infected with HIV and you're on medication, you can live as equal life as anybody that is not even infected with any disease. And if we can control the stigma, even within the community, that will go a long way for people to really come out. People are living in closets. People are dying of HIV because they don't want to come out. They feel if they come out, it becomes a big problem. So that's where the peculiarity about integrating with religious leaders in the community, the market women leaders, the youths, and every other partners we are already partnering with to ensure that we achieve these desired goals and targets.
Okay, I must commend you for what you do. However, I will take this to Dr. Fatima. Doctor, in what you do, I know that there was such a time, there was this ugly trend of people coming out to say, well, somebody gave it to me, so I'm on a mission to also transmit to others. How do you tackle such things?
Well, see, generally, I think, like we said, it's the perception of the disease itself. When people think that it's a death sentence, so they begin to get angry, want to maybe, like you said, back in the day, want to retaliate and say, okay, I'm going to infect other people. I think we've passed that stage, like he said. A lot of people are aware of what HIV is. A lot of people understand now that it's not such a disease whereby the minute you get it, you're about to die, and so on and so forth. So I think that, yes, the stigma is there. However, it is much reduced. The awareness about what HIV is and the treatment modalities that are out there is more than before. So people are less likely to behave in such a way. However, it is just, I think you were talking about behavior with Dr. Komolafe just before in the previous segment. And really, behavior change is something that takes time. So that's why you have to keep going back and talking about it like we're doing right now on the radio. And I think it's the reason why we chose the December 1st thing. So people globally, because it's celebrated globally, everywhere they're talking about HIV. So it raises more awareness. So people are like, oh, this HIV, so what is new? I mean, what is new? And then they begin to see, oh, really? So there's this, so there's that, so this is happening now and this is happening there. And I think all of that has really come down because it then tells you the prevalence all over the world is coming down. And that simply tells you when people get infected, they're not out to get other people infected as well. And it's only natural for you to walk into the doctor's clinic and you maybe just experiencing a headache and the doctor tells you, oh, by the way, you have a brain tumor. How would you feel? The people generally go through different emotions and everybody handles their emotions differently. But with HIV now, what happens is that before you get the test, that's why we counsel you. So we tell you the possibilities of what might happen if the test is positive, if the test is negative. And we counsel you after you get the test. So should you get a positive test, before we link you to treatment, you go through counseling as well. And they're never left alone. They're followed all through. There's different stages and different people that you're being attached to counsel you on your medication, to counsel you on social behavior, to counsel you on so many things. So I believe that the counseling does help because then the person begins to understand all the phases of the emotions you're going through. There's somebody to walk you through it. So I think that helps with that type of maybe behavior or perception towards the infection itself,
But I must also commend the work that you do because recently I've also had a lot of people come out to say, yes, I am HIV positive. I've been living my life like the regular person for years now. But what's the danger in that as well, where people perceive that in the bid to, you know, lighten that perception of, oh, it's a death sentence? Are they also still being lack of words to use, persecuted basically? Do they also face all of that? Because we are very conserved people back here.
Okay, just to add to what she said and to also respond to your question, you know, most times when people come out to say I'm HIV positive, for instance, you know, people still look at them with, you know, this faith that, okay, you're going to die someday. But the truth remains that people living with HIV live equal life like every other person. So the major issue that is actually leading to all this, and that is what we want to really, you know, tackle, which is a bottleneck in terms of, you know, disclosure. A lot of persons are infected. How would you come outright publicly to disclose your status, or maybe disclose even your status to your partner or your relative or friends? How would they see you? What's the perception? How do they perceive you? So this is one of the key things that we are looking at. If we can work closely to see how we can solve issues about non-disclosure of their status, and also the likes of adherence to the medication. These are those who are already positive, living with HIV, and then already on treatment. If you are not adhering to your medication, the tendencies of, you know, developing resistant strain of the virus, which will even affect or alter the medication you're taking, and thereby increasing the chances of transmission. And that is why we can still see new infections. So these are the things that we are worried about, that we keep enlightening people about what is the, as a reminder, in as much as we are already, you know, achieving the epidemic control. What about the likelihood of drug fatigue? You take this medication for years. How you get tired of taking the medication? And, you know, so the reason why we are commemorating this day is that we need to create more awareness, so that people who are already infected and those who are don't even know their status should be aware that, yes, I need to get tested. And in an attempt to be tested, you need to be counseled, just like she rightly said. When you are counseled appropriately, you wouldn't have the negative side of you being infected. What if somebody is even infected with, let's say, cancer, brain tumors, and all that? Do people stigmatize them? Yes, they still face some kind of stigma. But I bet you the perception of Nigerians, you know, when it comes to HIV, you see somebody with cancer, they would rather empathize with somebody with cancer as compared to somebody that has HIV. It is not supposed to be like that. Okay. And that is why there is a need for this drive, awareness campaign for
Dr. Fatima,
what is it.
He keeps talking about people who have this virus and do not even know that they do. How is that possible? And what's let's go back to you. In your response, I would like you to talk about the access to these testing facilities. If you don't have any reason to get tested, is there a way, would it be infringing on some people's personal freedom rather, if you insist that, oh, let's do a random testing? Or if you come to test for malaria, we check HIV in there. So what would your response there?
So ideally with HIV, we do not do compulsory testing. There's nothing like that. That's why he said, and we keep hammering on awareness and advocating and enlightening people, is because we usually would want a person to voluntarily come for testing.
Right.
Now, speaking to your question, yes, across the FCT, in all of our own facilities, government-owned facilities, and any implementing partner supported facility, HIV testing is free. So we have different modalities. You could walk in as on your own to say voluntarily, I'm coming for what we call voluntary counseling and testing. You could come in and we have what we call the provider-initiated testing and counseling. That is usually when you come in, maybe you're seeing a physician and the physician feels that maybe it's good for them to screen you for HIV. The physician is supposed to tell you that I think that I would like to screen you for HIV, and if you give your consent, they would send you for HIV testing. When we go into the communities to test, we do not force anybody to get tested. What we do is, like he said, we go into the community, we meet the gatekeepers, these people who we're allowing to lead, to speak to their people, to say, come out and get tested for HIV. So these people voluntarily come to us and we test them. So that's how we usually test for HIV. So no, there is no compulsion in testing for HIV. I do know that a few people mention when they come for antenatal, particularly pregnant women, where they say they don't get asks, they ask for HIV testing. They just get like a whole bunch of tests being ordered, and then, you know, HIV is amongst them. That is a wrong practice. The right practice is, yes, there should be routine things for ANC, but that provider should tell you that while I am screening you for anemia and so on and so forth, I am also doing a retroviral screening, probably screening you for other STIs. Now that we have something we call a dual test kit, where we can test pregnant women for both HIV and syphilis at the same time, you want to test them for hepatitis B, because sometimes the infections they live together, so we call them co-infections. So you would want to tell that person that you want to do these type of HIV and STI screening, so the person has to consent before you send them for these tests. But these tests are available across all of our facilities. They're available for free, and even treatment is free across the FCTA, and I believe across Nigeria as well. So most times we're practicing the WHO guideline of testing and treating. So what does that mean? That means that as soon as you receive a positive test, if we confirm that you are positive, we would make sure that you're linked to treatment immediately, unlike before. Because like Dr. Ifeanyi just previously said, what we're trying to do is avoid transmission of that virus. So the earlier we put you on treatment, the more likely you are to be suppressed, and the less likely you are to transmit that infection to somebody else.
Okay.
Could just also to add to what she said in terms of people getting tested, you know, most times it's dependent also on the adherence counseling skill of the healthcare worker that sees the client. Should, in case you walk into a facility and you don't want to get tested, maybe you opted out of being tested for HIV, the adherence counselors are there to counsel you on need, especially if you have practiced some sexual exposures that maybe in the past, or maybe you presented with the likes of some STIs, or you come in with some of chronic illnesses. You've come into the facility, you've lost weight, you're not looking good and all that. Clinically, if you're very bad, there is need for that counseling, and at the point of that counseling, definitely you'll be convinced to know your status, because at long run, it is better you know your status, yes, than not knowing your status while you're dying in silence.
Okay. Still talking about exposure to it, do you also have that awareness around the PEP, that's the post-exposure prophylaxis? Yeah, I wanted to sound really intelligent. Post-exposure prophylaxis. So is that also something, I mean, when we read about this prevalent in rape and all of that, often I keep saying, please get to the hospital and get there fast and ensure you do this. Is that awareness also rife in Nigeria?
Yes, it is well, the awareness is well created. In fact, when you go to all our facilities supported by AHF, we have a box pill where you can now, where you can report and ask, okay, should in case this happens to me, what can I do? And people are already there to really counsel you in respect to that. And the key thing about the post-exposure prophylaxis is a drive to also prevent the transmission of the virus, because a lot of persons could be raped, just like you've said, or maybe you have an exposure from maybe a ruptured condom in an attempt for sex, or maybe on sex activity that you unduly that you do not really require. And then if you're exposed, if you do not know the person's status who you are exposed to have the sexual intercourse with, you have the right also to have PEP to prevent, because you do not know the person's status, if you cannot trace the person. But the good thing is that if you can't trace the person and then you know the person's status and the person is HIV positive, there is every tendency that yes, once you take PEP, you have to remain negative, and you must also avoid all unprotected sexual intercourse during that period to which you're taking PEP. Usually taken for just 28 days, and after 28 days, you have your test done, and then you follow up with the subsequent test to make sure you end up negative. We all know that there is a space called the window period. And at the point of window period, what happens? That's when seroconversions happen. And when by seroconversion, I mean when the antigen converts to the antibody and all that, then the test kit can be that easily pick it when you do the test. So at this point, that is why it is very, very important we talk about the PEP. It's one of the key advocates for AHF, so that everybody that are exposed will not have the higher chances of getting infected with HIV and AIDS.
Maybe if I may add, so at the state level, what we're doing in terms of all of these things for PEP that he mentioned are there in place, but we're also working with the police. They've received some trainings, because you mentioned something about rape victims. They've received some training alongside our implementing partners that we're trying to teach them This is also looking at things like GBV, so gender-based violence, right? So we're enlightening the police particularly, because we found that most rape cases that are being reported to the police station do not get referred to the health facility till over 72 hours. And usually that's the window period for you to be able to offer somebody PEP. So we would want them to come within that window period where they can actually benefit from the PEP since it is available. So now we're training the policemen to refer them to the various facilities where they can receive PEP, and also training them to also be able to provide the PEP within the clinics that are available in the police stations as well, just so that we don't miss those people who are vulnerable. Already, you know, they're going through GBV, and then there's a likelihood of exposure to HIV. We want to avoid them getting infected, so we want to make sure we catch them within that window period. So that's also happening alongside the regular, you know, just your high-risk behavior or something like that to come in for PEP. Yes.
Right. I would like you to also address something a lot of people would want to hear as we speak. There are some people who will say, oh no, I've been with HIV positive patients and have not caught the virus. What happens in that instance?
So yes, it is possible. We have couples that we call non-discordant couples.
Non-discordant?
Yes. So the reason, what that simply means is that one of them has the virus and the other one doesn't. And like Dr. Ifeanyi had previously said, something about undetectable, untransmittable, right? So what that simply means is that, and that's why these antiretroviral drugs are actually a game changer. If you are positive and you stay adherent on your medication and you do all your testing and you keep your virus low enough to not be detected on the test, there's every possibility that you will not be able to transmit that virus. So yes, those type of couples could be together as long as the person who has the virus is able to keep their virus undetected. They're unlikely to pass the virus to the other person. And those people usually, the partner who is negative, they receive, you know, counseling, like he said. They receive regular testing also from time to time, and they're also entitled to in their case, it will be pre-exposure prophylaxis, right?
Yes.
As opposed to post-exposure, since they're aware of the person and so on. Yeah. But you see, this undetectable, untransmittable is also the idea behind the PMTCT, which is the prevention of mother-to-child transmission of HIV. And what we're simply trying to do in that case as well is to make sure that the mother's virus is so low that it's not, she's not able to transmit it to that unborn child, and therefore we're not going to be giving birth to HIV-positive babies anymore. She might be positive, but all her children will, if she goes through the program, be negative. And that's also another way to make sure that we're stopping the transmission of HIV. So this is what it is.
Yes, and also making sure that the babies have access to the prophylaxis too. Right. They also have a prophylaxis which they are given at birth, and then that's what they call EID services, early infant diagnosis tests that will be followed through. And then at 1 year and 6 months, the child will be tested and the child will be negative.
What happens after you have been declared undetected,
undetectable,
exactly? So what happens then? Do you still continue with the drugs, or have you also had people who say, "Oh well, I'm free now"?
Okay, thank you very much. You know, most times people think when you're undetectable, it means you cannot transmit the virus. But once you stop the medication, the virus, where they are hiding, they begin to replicate, and in fact they are coming dangerously, in the sense that they are coming with, you know, mutations, change, you know, because the drug that has been holding them is no more there. So whenever you're undetected, your viral load is undetected, the need for you to be on treatment is mandatory. That is the gold standard. Do not believe that when you have taken drugs to the level that you're undetected, then I have to stop medication. In fact, you're giving the virus to replicate, to even begin to produce resistant strain to the drug, because they will now learn new tactics of this is what has been depriving us from thriving. Now that it's no more there, new chance. In fact, it's good. There's going to be what they call a rebound of viral load multiplication. So the need is this: once you're on medication and you have achieved viral load test not detected, you must still be on medication to sustain that viral suppression. And once you have sustained that viral suppression all through your life while on medication, then we can now say that you're freely going to say that you can really not transmit the virus. These are the key things that is very, very necessary and for everybody to also understand.
Okay. Do you also still have, I mean, we have gotten to a point where the stereotype is largely reduced. We must give credit to that. However, I remember such a time where people would queue for others because they don't want to be seen in that queue. But are there now seamless ways of getting your drugs without saying, oh, that's the HIV line and they're queuing for retrovirals?
Okay.
Yes, thank you for that. So we've come up with innovative ways, if you ask me, of giving our clients medication. Yes, in some facilities you still have the HIV clinic as it was before, maybe domiciled in a particular part of the hospital, which is what you're talking about. And most people know that when people go behind or at the back of that container, that they're going for HIV treatment. However, we've come up with different modalities, different what we call differentiated service delivery.
Differentiated
service delivery, so DSD models. So what we have is we have things like family pickup, we have community pharmacies, we have the multi-month dispensary of drugs, we have the one where what do you call it now?
And the facility based.
Yeah, facility based. So you can choose to come to the facility to take your drugs, but this is usually for people who are already adherent on their medication. We're sure that they will take the drugs, and anyway, we have other modalities to keep tracking them and talking to them, and like you said, the adherence counselors do their jobs to ensure that they keep on drugs. And we target like young people, like adolescents. Now there's adolescent-led models, right, where they either have like evening clinics, or they have like ones that are led by adolescents, where they come, they have a focus group, and so on. So all these are targeted at different, at different age groups, but also at different people, so that for instance, if it is a family that is HIV positive, you can now have the father come in this month, take the drugs for all of them, the mother come in the next month. So everyone doesn't have to come in, everyone doesn't have to leave what they're doing to come in for the drugs, but it makes it so much easier, and it's cheaper for one person to take it. For the multi-month is usually for people who are maybe more virally suppressed and also more adherent on their drugs. So instead of coming monthly, we could give you your drugs for 3 months, some take it for 6 months, and so on, before we have to see you again. And like he said, for the adolescents, we target them, they go to school. You can't expect them to come during the day, so you would want them to come in the evening, so you run the clinic for them in the evenings. And also, there would be less people in the facility if they're worried about being seen. So we've tried to come up with innovative ways to also help them get their medication without, and also the hub and spoke modeling too. It helps. So we have people, yes, like you said, who maybe were tested within their community but don't want to take the drugs there because the matron is actually her neighbor. So she would much rather, and she would ask that, can you send me to another facility? So the hub and spoke model helps in such a way that you can move her from that facility to maybe one that is much closer to her, but where those people don't know her and she doesn't know them. So yes, this is still happening because stigma is still rife and is still out there, and you want to make the person as comfortable as possible to take their medication to stop transmission of the virus.
Okay, just to add to the DSD, and one key thing that you must understand, DSD, that's differentiated service delivery. So one key thing you must understand is that you must have to meet a criteria, which she has already said. Those criteria: you must be virally suppressed, you must be adherent to your medication. Yet, just like the name DSD, there are some peculiar clients where you have to give preferential treatments, like the new clients who are naive clients who come with advanced HIV disease, clients like the mother to child, pregnant mothers. We give them shorter dates whereby they can now get informed about adhering to their medication and intimate them why they should be adhering to medication. And on that route, it helps to really make them understand the reality on ground, so that they can now become adherent to medication. And if you are adherent to medication, that means you must have what they call the ART literacy program, like more of like an adherence club. The more you meet the healthcare worker, the more you get counseled, the more you know that yes, you can actually stand on your own to take this medication before you can now graduate and then be clustered into or devolved into different starting groups, which the DSD can entails.
Right. Nobody has spoken about what it costs to have these retrovirals. Are they free?
Yes, I mentioned that initially.
Right.
So with collaboration with PEPFAR, Nigeria has been receiving free antiretroviral drugs for years now. So all patients are being linked to care and their drugs are free.
Wow.
Yes.
So
You don't pay a
that's why
dime.
we're saying testing is free, linkage to care is free. So really you
Treatment
just
is free.
need to get tested, know your status, and everything will fall in line, and you'd find that it's not so bad after all.
It's not so bad after all. That's the message we are sending. However, what are the plans? What are the activities you have rolled out? I know the AHF often has so many activities, but I would like to start from you. What's the plan?
So as usual, every 1st of December, we collaborate with, like he said, all of our stakeholders. So it's FACA, it's the implementing partners in the state, AHF included, and everybody else. And what we do is that we try to come up with common things to do. Like for this year, we're going to have a flag off at Area 10 Parade Ground. So there's going to be testing happening there as well. We're going to flag off the World AIDS Day commemoration. We're also going to have a road walk where, it's just sort of the enlightenment thing we're talking about. So people see you walking and they see we hand out flyers, we hand out IEC material, we get people to come along with us and then to get tested as well. We have little pockets of testing which will continue across all of our facilities and our implementing partner facilities. That is not going to stop just because World AIDS Day has come around, and it is year-round, so that is continuous. We're going to have little bits of this type of interaction, with the media, on radio, to get people to understand what HIV is, why they should get tested, and so on and so forth. So these are just the general things. We want to make sure that there's awareness creation, that testing is being done, that people are being linked to care. So there will be health sector response and there will be the non-health sector response, which is around prevention, maybe distribution of free condoms and giving talks for people to know how to stay safe and so on.
Okay. Yes, AHF, AHF as an organization, its Healthcare Foundation is one of the key advocates for HIV and AIDS. And then World AIDS Day is usually commemorated every 1st December. And HF has been the front line when it comes to creating the awareness so that people will know their status. And we collaborate with FACA, the House of Assembly. In fact, we have the Honorable Amobi Oga. He will be also, that is the chairman for House of Representatives, Committee on AIDS, TB, and also malaria. Will be flagging up the HIV, what is the with AHF. We'll be involved in work, to create awareness in respect to that. And one key thing about AHF is that we are in 7 states in Nigeria. And these 7 states, including Abuja, most of our facilities are running testing as we speak right now. Communities where we are working, testing activities are currently going across all the sites. And not only the testing activities, we also have to also come. We are also joining the SARS cap at the level, at that state level, to also commemorate the World AIDS Day by creating awareness that people should know their status and also get treatment. We're also doing the likes of testing on the grand opening where we are flagging off at Area 10. Testing activities also will be going on there. As we speak right now, the testing activity does not just stop. It spans even in December all through, because it's a month which we have set out our targets to make sure everybody get tested. So I'm asking people, urging people to get tested. These are the key things, because if you can only get to know your status when you are tested, and if you're not tested, you will not know your status. So these are the key things that AHF is doing currently as we speak, in respect to what is the commemoration.
Okay, so tell us the advice you have for the FCT communities that are watching you right now.
So my advice is one: if you get tested, you know your status. You know your status, you can get the help that you need. So let's all come out, let's get tested, let's know our status, so that we can have an HIV-free community in the FCT. Thank you.
And
okay, my advice is that the issues surrounding stigma should stop. Nobody is perfect when it comes to being infected with HIV. No matter how careful you are, if you are not infected, you are also affected. Exactly. Because definitely you have friends or relatives, even people you look up to being infected with HIV. The stigma should be the one key thing that I want everybody to let go, and then allow people who live with HIV to live their normal life like every other normal person in the country.
I must commend you for the work that you do. Thank you so much for coming to the station to enlighten us here as well. For viewers at home, remember tomorrow is World AIDS Day. You can stop by the old parade ground, get tested. You can join the walk as well. If they have to join the walk, what would it entail?
So they just come, we're taking off from GSS Gerki, the one not far from the parade ground, and then we're going to just walk all the way to the parade ground for the flag off, so they can join us there.
Yes, you can join the walk as well if you have to help in advocacy, which is very important. So you can join the walk as well. It's going to be happening tomorrow. I will be there. I think I would chat that